Okay, friends, on behalf of the American College of Academic Addiction Medicine, welcome to a very special National Addiction Medicine Didactic Curriculum session. Many of you probably know, but today is International Overdose Awareness Day, and we have a very special session planned for everybody. So hello and welcome. For those of you who are new to our group, we are the American College of Academic Addiction Medicine. We are a group of academic addiction medicine physicians, and we proudly receive zero funding from pharma and zero funding from industry. Our mission is to promote academic excellence and leadership in addiction medicine. Our vision is to develop and support ACGME accredited fellowships and credentialed faculty, promote high standards and evidence-informed science that is free of outside influence or bias, integrate and teach an addiction medicine curriculum in all medical schools and residencies, and represent the interests of academic addiction medicine to stakeholders, including the public, and advance a formal presence of addiction medicine across medicine and healthcare. I have the privilege of telling you about several of our programs that are available for you. The first on the left-hand side of your screen is a question bank. This is our newest product and the latest way to prepare for the ABPM Addiction Medicine Subspecialty Board Exam. This ACAAM Addiction Medicine Board Prep Question Bank was developed by addiction medicine leaders and addresses all 17 core content areas of the ABPM exam content blueprint. The QBank includes 187 questions with answer explanations and references. The questions, importantly, are the same as those in the addiction medicine e-practice test known as ADEPT. But they're offered in a study mode, which provides purchasers instant access to the correct answers, explanations, and references. We feel that physicians wishing to assess their knowledge in the field will also find this to be a very helpful tool. On the right-hand side of your page, you'll see some information about the ACAAM Core Professional Practice Bundle. This is designed to have you save more as you buy more. And by buying two of our most popular learning tools together, you will save over 20%. Again, we have no pharma or industry support, so we're grateful for your membership. The bundle includes the 85 self-assessment modules known as SAMs, and all of the wonderful didactic session recordings throughout the year. So members receive access to SAMs and the live didactic recordings. If you are interested in our great organization, we encourage you to go to ACAAM.org, that's ACAAM.org, to see how you can join. So I have the great privilege of introducing Dr. Alex Walley, who many of you probably know wears a number of hats nationally and importantly at the addiction, we'll have to go back. We'll talk a little bit about the Career Center, excuse me. Don't forget about the Career Center, like I just did. This member benefit is your go-to resource for both finding a new position and recruiting qualified candidates. The Career Center lists opportunities for both full-time and part-time positions within academic health systems, non-academic health systems, and other places. For those of you who are seeking positions in our great field, ACAAM's Career Center makes your CV available to professional institutions and organizations in the industry with free and confidential CV posting. Job posters have access to review the CV of any physician who has chosen to upload their CV to the Career Center as well. And pricing is available for both members and non-members. There is quick access via a QR code to the ACAAM product page. You can take a photo of the screen to learn all about our various products, bundles, and other things using your phones. As I said just a moment ago, have the great privilege of introducing Dr. Alex Walley from Boston University Medical Center. Many of you, of course, know Dr. Walley, who wears many hats nationally and in Massachusetts as well. He has a wonderful interdisciplinary team of folks who are going to talk to us today. Dr. Walley and friends, please take us away.
Thank you, Tim, and thank you, ACAAM, and everyone who's joining today. I've been really looking forward to this. Some of you may know that I'm on a sabbatical this year, and so I've been trying to do some rejuvenation and focus on some of my research interests. Very excited to be here representing the Graken Addiction Medicine program at Boston Medical Center. I want to send a shout out to the fellows and faculty, in particular, Alyssa Peterkin, who's our program director. We've got 2 hours of content today, and we're calling it Working Together to Reduce Harm and Improve Safety for People Who Use Substances. As Tim mentioned, it is International Overdose Awareness Day. And the first hour is going to be a didactic. I'm going to focus on harm reduction in addiction medicine. And these are the learning objectives. So at the end of this session, you'll be able to define harm reduction and integrate it into addiction medicine. You'll be able to use rationale and evidence for needle syringe access, naloxone rescue kits for overdose prevention, supervised injection facilities or drug consumption spaces, and more. As I think Tim mentioned, the chat function is disabled during this webinar, but the Q&A function is active, so please feel free to use it. I'm hopeful that there'll be time for us to have some interaction through the Q&A, both in the first and the second hour. So Tim introduced me. I appreciate that introduction. I do want to I have one disclosure that I want to mention, which is that I've received honoraria via contract with JSI Research and Training Institute, which is a nonprofit, and the BU Department of Medicine to produce a monthly podcast called Connecting Care, which has been focused on the care of people with opioid use disorder and HIV. This is funded by HRSA's Strengthening Systems of Care for People with HIV and Opioid Use Disorder. And if you're interested in that podcast, it's available free on the internet. So we are at Boston Medical Center, which is in Massachusetts, and I want to acknowledge that Massachusetts is the original homelands of the Wampanoag, Nipmuc, and Massachusetts tribal nations. I recognize that they have endured loss of land, culture, language, and underwent oppression since the time of European contact, and I want to honor and respect the thousands of Indigenous peoples connected to this land. And I'm striving to learn and honor the rich traditions and ongoing contributions of Indigenous peoples with gratitude. Also, again, want to acknowledge that today is International Overdose Awareness Day, August 31st. This is a tradition that was first started actually by people in Australia over 20 years ago. This is a photograph in the background of 20,000 purple flags that were put in the ground at the State House in Massachusetts in Boston on Monday, representing the 20,000 individual people, residents of Massachusetts, who've died over the last 10 years, which is really breathtaking to witness. And I have photographs of 2 of those people who died in the last year. Paul Bowman, my friends, really, Paul Bowman and Mark Kinsley. They're huge losses to their families, to their friends, and really to the community of people who care for people who use substances. And so I'm thinking of them today, and I'm thinking of the many, many other people who've died from overdose and their families. So it's a sober day for us. And again, I'm grateful for you sharing it with me today, and hope that you'll have some time to reflect on the people that you've lost or the people that are connected to people who've been lost. So I think harm reduction is an appropriate topic for today. I'm no expert, but I'm somebody who has been practicing and learning for a long time now. And it's become particularly important in the work that I do as an addiction medicine physician. So what is harm reduction? It's practical strategies and ideas to reduce substance use consequences. That's really kind of the simple, and it is as simple as that. It's trying to reduce harm. It also is a movement for social justice that's built on a belief in and respect for the rights of people who use substances. And there's a national organization, which you can find at harmreduction.org. Some things to emphasize is that interventions in harm reduction are guided by a risk-benefit analysis. So we're trying to do more we're trying to do more good than harm. And it means that we come to it without preconceived notions about abstinence. So abstinence is not a prerequisite to care. The mantra that comes from Dan Bigg, who I'll show later, is really any positive change. So if we're making any positive change, we're doing harm reduction. Harm reduction for the first time has been specifically named in the federal drug policy priorities of the Biden-Harris administration. And so here are the 7 focus areas of drug policy. And you can see number 3 is enhancing evidence-based harm reduction efforts. And there's been evidence-based harm reduction efforts for quite some time, but this is really the first time that the federal government has been so explicitly supportive of harm reduction. And so this is a new dawn, I think, for many of us. I also have bolded here racial equity, advancing racial equity issues in our approach to drug policy. And this is also explicitly called for. And I have both of them bolded because in many ways they're related and reliant on each other. And I'm gonna highlight that in several areas here today. So some of the specific harm reduction strategies, you see the terms SSP, which is Syringe Service Program, and then naloxone. FTS stands for fentanyl test strips and linkage. And so these are harm reduction strategies that are now supported and endorsed by the federal government, and federal funds can be used to pursue these. The CDC now has a harm reduction technical assistance center. And here's the statement from their face page. Harm reduction programs are an effective component of community-based programs preventing infectious disease, overdose, and other negative outcomes related to using drugs. And the National Harm Reduction Technical Assistance Center is designed to strengthen the capacity and improve the performance of syringe service programs and other harm reduction efforts throughout the United States by supporting enhanced technical assistance to ensure the provision of high quality, comprehensive harm reduction services. So I want to spend a little bit of time talking about why harm reduction is necessary. And today is International Overdose Awareness Day. My first example, though, really is focused on HIV because while HIV and overdose are not the only topics that harm reduction addresses, HIV prevention certainly plays an important role in the development of harm reduction. And I'm just highlighting this one particular moment in rural Indiana and Scott County in 2014, 2015, where there was an HIV outbreak in a rural area. A single strain of HIV spread rapidly within a dense network of people who were injecting drugs. So they were actually injecting a prescription opioid, oxymorphone, which is no longer on the market. And through their injection practices and really lack of harm reduction, HIV spread quite quickly in this small community. And so this funny looking figure is a network diagram. And since many of us are on Zoom, you can squint your eyes and put your eyes close to the screen and really kind of see in high detail what's going on. Every dot on this represents a person. And if the dot is red, it's somebody who was newly diagnosed with HIV in the course of the outbreak investigation. If they're connected to somebody by a solid gray line, they're connected through syringe sharing. And if it's a dotted dark line, it's through sexual risk or sexual behavior. The blue dots are people who tested HIV negative. And so what you can see here, I think, is immediately apparent, at least to me, is that people are quite social and they engage with people in dense networks that maybe aren't as immediately obvious or more connected than we think through, in this case, in this community, syringe sharing and sexual risk. In this, what's a little bit unusual in this network diagram of HIV transmission is that syringe sharing really dominated. In many others, it's sexual risk that dominates, but this just shows that syringe sharing, especially the way that Opana was being used, can really, unfortunately, efficiently transmit the HIV virus. Now, you'll see that not everybody who's connected to everyone else has the same status. So it does mean that some people, when they're affiliated with other people, there is transmission, and other people there are not. And some of the things that that is driven by is frequency, but also the specific practices. You'll also notice this group off to the right who's not connected to the wider network. And so I've often asked myself, well, what's that about? And I think that's people who had risk within their smaller network, but did not acknowledge any connection to the bigger network. And I think that's just a sign, one of the many signs of stigma, of people not really speaking openly about these behaviors, even to the CDC or public health investigators. And then the last thing I want you to notice is that there actually, as you look closely and squint, there are a lot of gray dots. The gray dots are individual people who were never tested during this outbreak investigation. And so even in the setting of what happened in Scott County, where there were state and federal resources of unseen before proportions that were marshaled to try to address this outbreak, there were still people who were not able to be reached, to be tested, or refused to be tested, which is another sign, I think, of the stigma of substance use and of HIV. And one of the things that harm reduction does is it tries to really meet people where they're at and address that stigma, to try to engage people on their terms. And if you, in the setting of, say, punishment or criminalization, that only is going to ramp the stigma up, and you're going to have more and more gray dots, and you're going to have more and more people who are isolated away from the rest of the network. So that's one of the take-home points that I really wanted to make. Here you can see this, the data of cumulative HIV diagnosis in this community over a one-year period, where you went from initial diagnosis to a cluster identified, a public health incident command was established. They started doing more widely HIV testing. They requested federal support. They had a public health emergency declared. By the way, that was declared by Mike Pence at that time, who was the governor of Indiana before he was vice president, and had been, before this outbreak, strongly against syringe service as something that encouraged substance use, but then reversed course and began to be a supporter of syringe service in response to this outbreak. Local HIV clinic opened, and then syringe service exchange or syringe service started, which resulted in the end over 77,000 syringes dispensed. And you see, it was once that syringes were being dispensed that the transmission rates plateaued and stopped growing at the really astronomical rate they had. So a lot of people after this attributed this to it being a rural area that didn't have resources and was otherwise isolated from healthcare and public health. In Massachusetts, we are quite humble because we have universal healthcare coverage. We have a lot of the things, including syringe service and medication for opioid use disorder and other known effective means of diminishing the harms from substance use, from opioid use. But we still, in our communities, particularly in those that were faced with high levels of homelessness, poverty, sex work, and stimulant use, so that included Lawrence, Lowell, and Boston, we've had ongoing HIV outbreaks. And so harm reduction is a very important part of the solution. It's not the only answer. At the end of the day, what we need to be engaging with people on their terms and trying to help them get what they need. So a little bit more about the data behind syringe service programs. So here's a meta-analysis from the 1990s. This has been around for a long time, which showed of studies across multiple cities in the world that cities with needle syringe programs had a reduction in their HIV transmission rate of almost 6% per year, whereas cities without needle syringe programs have a growth in their HIV transmission rates of 6% per year. In cities with low seroprevalence, they may not have as quickly of a reduction because they have low rates to begin with. But if they don't have syringe service programs, they have a higher rate of increase. And so this is the argument that even if you don't have an HIV problem in your community, if you want to prevent one from happening in the future, you really should have one of these programs. Here's a flyer from the CDC, which summarizes the evidence from studies over the last 30 years. So syringe service programs save lives by lowering the likelihood of deaths from overdoses. They not only involve access to sterile injection supplies, but they provide counseling and testing. They prevent outbreaks of other diseases. They're associated with a 50% decline in the risk of HIV transmission over time. People who use SSPs are 3 times more likely to stop injecting drugs. Law enforcement benefits from reduced needle sticks, no increases in crime, and the ability to save lives by preventing overdoses. When 2 similar cities were compared, the one with an SSP had 86% fewer syringes in places like parks and sidewalks. So syringe service programs actually contribute to reducing drug material waste rather than increasing them. And so this is a schematic that kind of shows what they do. So you have at the front door there access to safe and safe disposal of sterile syringes and injection equipment. There's counseling on treatment and prevention of infections like hepatitis B, access to antiretroviral therapy for people with HIV and pre-exposure prophylaxis, which is an important harm reduction measure, referral to substance use treatment, medical care, mental health services, and other support services, and then vaccines for hepatitis A and B treatment or testing for diseases like HIV and hepatitis C. I just want to acknowledge the person who really started syringe service program right here in Boston is Rhoda Kramer, the woman there on the right. She's there with her colleague, George Arlo. They started the syringe service program at AHOPE here in Boston, which is still the largest syringe service program in Massachusetts, and really a leader. So I'm going to shift to think about overdose. It is Overdose Awareness Day. Overdose is the leading cause of accidental injury death by far, now responsible for more than 100,000 overdose deaths a year. That outstrips firearm deaths and motor vehicle accidents combined. And here you can see the really astronomical growth between 2000 to 2019 of drug overdose deaths. There was this plateau in 2017, 2018, and 2019, but now we're surging again in the midst of the COVID pandemic. And fentanyl is driving this overdose surge. So this is, again, only up to 2019, but you can see deaths that involve fentanyl, also deaths that involve stimulants, including methamphetamine and cocaine were increasing, whereas heroin and prescription opioid deaths have sort of plateaued and decreased in recent years. So we're in a new phase of overdose over the last several years. So these increases in fatal overdoses across the United States have been driven by synthetic opioids, both before and now during the COVID pandemic. So here in the dark blue, you can see surges in overdose deaths that continued as the COVID pandemic started in 2020. And that really impacted almost every state in the country. And so it's something we're all facing. Some recommendations from a CDC Health Alert Network on how to address this was to expand the provision and use of naloxone and overdose prevention education, to expand access to and provision of treatment for substance use disorders, to intervene early with individuals at highest risk for overdose. I would say in order to intervene early, the best way is through using harm reduction engagement efforts, and then improving detection of overdose outbreaks due to fentanyl, novel psychoactive substances, or other drugs. So this surge in fentanyl has not fallen evenly on all populations. It actually, as many of the health ills, including the COVID pandemic and other inequities in our society, it's fallen on some racial ethnic groups more than others. And in this case, like between 2013 and 2017, non-Hispanic Blacks saw an 18-fold increase in their fentanyl-related overdose death rates. Hispanics saw a 12.3-fold increase, and non-Hispanic whites saw a 9.2-fold increase. I need to mention that there's an increasing but unknown number of people who do not have opioid use disorder who are overdosing due to fentanyl contamination of cocaine, methamphetamine, and counterfeit prescription pills. We do not have great ways of counting this or detecting this, but it has become clear through the many case reports that I listed here on the slide that people without opioid tolerance are unwittingly being exposed to fentanyl via non-opioids and are overdosing, that fentanyl-related overdose is on the rise in people in particular who use methamphetamine and cocaine. And so the implications here for harm reduction are that overdose prevention efforts need to expand beyond just people who use opioids, and we need to innovate to focus on engaging people who use stimulants and counterfeit non-opioid prescription pills. So here's just one example. There's very similar data on methamphetamine that shows these surges of overdose deaths involving cocaine on the left. Most of those are overdoses where there's cocaine and opioids involved. And that we see these in all parts of the country. I want to focus for a minute on Massachusetts because that's where I am today. I'm thinking about, and I've been spending time really since 2007 working on overdose prevention. If you look on this graph at 2007, we had 640 overdose deaths from opioids. And that actually was seemed like it was quite high because there had been some substantial increases. We were concerned about that. And that's when we started doing naloxone distribution. It's also the same time, 2007, when we had the first universal healthcare coverage under Mitt Romney, who was the governor. And there was also an expansion of treatment with buprenorphine. And basically overdose deaths decreased or plateaued between 2007 and 2011. We thought we were doing quite well compared to other states that had increasing rates every year. But then in 2012, 2013, 2014, that's when fentanyl really started to come to Massachusetts, and then in earnest, the whole state in 2016. And despite all of those preventative things, the drug supply was particularly dangerous, and we saw this surge in overdose deaths. And we have had that over 2,000 overdose deaths for the last now 6 years. And again, like I mentioned nationally, the impact of these deaths have not fallen equitably across our population. So from 2014 to 2020, the overdose deaths, or really from 2016 to 2020, overdose deaths had flattened or gone down across all populations, and particularly among white non-Hispanic folks. But in 2020, we saw this dramatic surge in Black non-Hispanic residents in Massachusetts, almost a doubling of the rate. So remember, this was the pandemic year. Many other inequities, health inequities, were survived by or encountered by Black residents. And then we also saw increases among Hispanic groups. Now, in 2021, these are the same numbers except for the red bars, but the scale is different. The reason the scale is different is because this was the first year the state of Massachusetts looked at American Indian non-Hispanic people. And it turns out that they actually have 3 times the overdose death rates of any other ethnic or racial group. and it has been erratic year in, year out, but always high and largely increasing over time. And so this has been a giant blind spot, I think, for public health. Population of our original inhabitants who are here with us and are living, but they're also dying from overdose. And so this is a place where we need to spend and put more attention. So fentanyl, it kills. We have a drug supply problem. We noticed this in Massachusetts. It took a while, but we noticed in 2015, 2016. We did an epi-aid investigation in southeastern Massachusetts looking at deaths and survivors, overdose deaths and overdose survivors. This quote kind of sums it all up. So now what they are doing is they're cutting the heroin and the fentanyl to make it stronger. And the dope is so strong with fentanyl in it that you get the whole dose of fentanyl at once rather than being time released like the patch. And that's why people are dying, plain and simple. They are doing the whole bag and they don't realize that they can't handle it. Their body can't handle it. So I'm going to spend some time talking about naloxone because naloxone, even though the fentanyl supply is more fatal, naloxone does work with fentanyl. It really in the US started with this man here on the left, Dan Big. You can see his t-shirt says any positive change. This is the Chicago Recovery Alliance's van that they did outreach on. And they first started in the late 90s distributing naloxone to people who use drugs. This was really not a sanctioned practice at all. It was Dan's vision. With his vision, he is really, it's the shoulders of his that we stand on as we're now have what is really mainstream naloxone distribution. So endorsed by, so community distribution of naloxone to people at risk for overdose and their loved ones is endorsed by the AMA, the American Pharmacists Association, the National Drug Control Strategy since 2013. They didn't mention harm reduction, but they did mention naloxone distribution. The American Society of Addiction Medicine, the World Health Organization, the Surgeon General since 2018. And that is based on not randomized controlled trials of naloxone in the community. There are strong trials that show that naloxone works in the lab, but on the community level, it's been a series of observational studies that build this staircase of evidence that show that naloxone distribution is feasible. It increases knowledge and skills. There's no increase in drug use by distributing people naloxone, but there is an increase in drug treatment. There's a reduction in overdose in communities, and I'll show you an example. And then it's cost effective. One of the most cost effective preventive interventions we can do. And then it's also now endorsed as part of out-of-hospital cardiac arrest. It should be part of how we are responding to people in the community who are unresponsive. Okay, so what's the case for it? Well, most people who use opioids do not use alone. We know what the risk factors are. It includes mixing substances, abstinence, using alone, and an unknown source. There's an opportunity window. So opioid overdose takes minutes to hours and is reversible with naloxone. Now that's the old opioid overdoses. With fentanyl, this window has narrowed. Instead of minutes to hours, overdoses evolve over seconds to minutes. So there's still a window to intervene, but it's narrower. And that's really the reason why we see more overdose deaths with fentanyl. Bystanders are trainable to recognize and respond to overdoses, and there's a fear of public safety. So what's that mean? Fear of public safety? Well, it means that no matter what we do, not everyone's going to call for help when there's an overdose because they fear of the downsides of public safety, and that some people more than others, but especially people who are using substances who've been criminalized and have a history of conflict with the police. So we need to provide people with other tools, even if they won't call for help. And even if they do call for help, this narrow time window gives us, not enough time while we wait for public safety to arrive. So we looked at the impact of of distributing naloxone in Massachusetts early on. So there was, this is the state of Massachusetts divided up into its 351 towns. The darker the shading, the more overdose deaths that occurred between 2004 and 2006. So the darkest towns are the larger population centers. The first OE&D, or overdose education and naloxone distribution programs, were started in Boston and Cambridge in 2006 and 2007. And then the state health department funded the expansion of programs like this to these other communities, which you can see in the green diamonds. And then further in 2009. In 2009, there were many towns that had multiple overdoses, but had no naloxone programming. And so the difference between the circles and the diamonds allowed us the opportunity to conduct a natural experiment where we compared overdose rates in the towns that had programs to the towns that did not have programs. And here's what we found. So in communities where there was no naloxone distribution, we consider the rate of opioid overdose death rate to be 100%, sort of the baseline is 100%. And then in the communities where there was low implementation, so between 1 and 100 kits of naloxone, or two doses in a kit, were distributed per 100,000 people, we observed a 27% reduction in the opioid overdose death rate. And then in the communities where there was greater naloxone coverage, over 100 naloxone kits per 100,000 people, we saw an even greater reduction in the opioid overdose death rate. So not randomized controlled trial evidence, but some strong observational evidence that the implementation of naloxone programming can be associated with a lower opioid overdose death rate. Now, at that time, and even up to the present, the great majority of naloxone distributed in the community was distributed through harm reduction programs. So the yellow bars here, this histogram presents the number of dispensing events per quarter in Massachusetts. And you can see that quarter to quarter, the largest fraction of naloxone is coming through community OE&D programs. Now, there's an increasing number of naloxone that is being distributed through pharmacies, both through pharmacy standing orders, where you just walk into a pharmacy and ask for naloxone rescue kit, and they bill your insurance, or you pay cash and walk out, or where you actually get a prescription, which is the green, from your prescriber, and they prescribe naloxone to you. So there's various naloxone distribution streams, and if, as an addiction medicine specialist or addiction medicine fellow, now you may be wondering, well, what are the ways that I can help distribute naloxone? Well, the first one is partnering with harm reduction providers to get naloxone to those at highest risk for overdose. And that's often facilitated in many states through a community program standing order. Then there's facilitating pharmacy distribution, either through a statewide standing order or insurance coverage, or prescribing naloxone directly. Then there's engaging addiction providers at federally qualified health centers and emergency departments, because they're seeing high-risk people. And lastly, first responders. So first responders like obviously EMS, but also fire and police, they can administer naloxone when they respond to an overdose. And they can also increasingly in many communities be able to leave naloxone behind for the friends and family or the survivors. So just a little bit of research on the prescribing of naloxone to opioid patients. So this was a non-randomized intervention study of naloxone co-prescription for primary care patients receiving long-term opioid therapy for pain, led by Philip Coffin's group at the San Francisco Department of Public Health. And so what they did was they created an implementation project where they sought to have everybody who receives long-term opioids co-prescribed naloxone rescue kits. The first part of this was they had a 38% success rate after training the prescribers and trying to reduce some of the barriers. So it depends on whether you're a 38% full or a 62% empty type person, but it's certainly better than 0%. So they got 38% of these 1,985 patients to get naloxone rescue kits. Who got the naloxone rescue kits among the long-term opioid patients? Well, it's patients with the higher opioid doses and previous opioid-related ED visits, they were more likely to get the kits. In those people who got them, their ED visits were reduced by 47% at 6 months and 63% at 12 months among those who were co-prescribed compared to those who were not. So that's a pretty substantial difference in emergency department utilization. Interestingly, there was no change in net prescribed opioid doses for patients co-prescribed naloxone. So as an addiction medicine provider, if you're not prescribing naloxone to opioid patients, and I would argue now, if you're not prescribing naloxone to your patients who are using stimulants or counterfeit prescription pills, you're really outside of the mainstream and you're outside of recommended practice. Whether you subscribe to harm reduction or not, this is really the standard of care now. Naloxone prescribing, it's even more important since the COVID-19 crisis. There's been more take-home doses of methadone, which is a good thing. But it also means that it's a good idea to have more naloxone out there. There's greater social isolation, stress, and anxiety that can lead to worsening mental health and addiction symptoms. Early on in the pandemic, EMS services might have been overwhelmed and slower to respond, and the community naloxone distribution might have been more limited during the crisis. There were some pharmacies, and not so much in Massachusetts, but in other states, there are pharmacies that may not stock naloxone. And so you should, one thing you can do as a prescriber and an advocate is to consider working with a local pharmacy or local naloxone distribution programs to ensure that their patients have the ability to fill prescriptions. State laws nationwide have drastically increased patients' ease of access to naloxone through pharmacies. So the great majority of states permit pharmacies to distribute naloxone without a prescription via a standing order or a collaborative practice agreement, or in some cases, pharmacists have their own prescribing authority. People not at risk themselves for overdose may receive naloxone via third-party distribution. This is unique among medications that we prescribe as addiction specialists. Usually we're prescribing to people who are actually going to take the medication. But in the case of naloxone, we actually many times want to be prescribing to the person who's going to administer the medication. And that's typically not permitted, but with naloxone in many states, it is permitted. That's called third-party distribution. Pharmacists are immune from liability for furnishing naloxone, and in some states, like Rhode Island, there's mandated insurance coverage. It's on the formulary, by the way, in many Medicaid programs, including Massachusetts. Okay, so some of the basics that you want to teach patients, family, friends, and caregivers. Number 1, recognize an overdose. Number 2, call for help. 3 and 4, administer naloxone as soon as it's available and perform rescue breathing or chest compressions per your level of training. And number 5, stay until help arrives. And if somebody starts breathing again, place them in the recovery position. So this very much aligns with basic life support, first responder. And in fact, it's now been incorporated into the American Heart Association guidelines, both for community and health worker first responder response, CPR. And so another way you can advocate is when you or your colleagues are getting trained in CPR, recertifying, which you all need to do while you're in fellowship, is to make sure that there's good quality naloxone instruction as part of that CPR refreshing course. This is kind of the big clinical pearl that I'm going to leave you with while you're thinking about how you're going to interact one-on-one with a patient, is that you should be, with each of your patients, making a risk reduction plan. What does that mean, and how do I do that? Well, how I do it is I ask all my patients, how do you protect yourself against overdose? And many times patients will say, well, I'm in treatment, doc. Why are you asking me about overdose? I'm not going to overdose when I'm in treatment. And I say to them, well, that's a fantastic plan A, and I fully support it, and I want to know how I can help keep you in treatment. But I need to know what your plan B is. And usually patients will get that, and they'll say to me, some of them will say to me, well, my plan B is to call somebody when I'm having urges. And I say, well, that's a great plan too, and I support you in doing that. But I need to know what your plan C is. What happens if you actually have made the decision that you're going to use, or you do use? What is your plan to keep yourself safe? And then hopefully I hear what the patient says and they have some ideas like, I'm going to use when someone else is there. I'm going to start low and go slow. I'm going to try not to mix it with other sedating substances. And now more and more, I'm going to test my drugs before I actually take them. So those are things that I'm looking for people to come up with as far as their safety plan. I'm going to make sure that the person with me has naloxone and is ready to administer it in case I overdose. So those are all the things I'm looking for in their risk reduction plan. For people who are prescribed opioids, I ask them, how do you keep your medication safe at home? And that's because a lot of medication ends up getting into other people's hands, and that's can cause dangers. And people need to recognize that these medications should be locked up and kept secure so that they are safe. I also ask about their plan if you witness an overdose, because many of my patients actually are more likely to witness an overdose than actually experience an overdose. And I want to help make sure they have a plan on how they're going to respond. And this is where that algorithm that I just showed you comes in, about calling for help, recognizing the overdose, calling for help, administering naloxone, doing rescue breathing or chest compressions, and staying with the person. And then have you received training to prevent, recognize, or respond to an overdose. This training is especially important for people using fentanyl, and now more complicated with the COVID-19 pandemic. So we want people to start low and go slow. If they're going to use opioids, we want them to use a small amount and give slowly to gauge the potency. This is really important for fentanyl. Before the COVID pandemic, we had said use with other people present and take turns to prevent simultaneous overdose, have naloxone ready, and an immediate way to call for help. Those things all still apply. But during the COVID pandemic, for some people well before it, but during the COVID pandemic, it became clear to me that we're going to have people that use alone no matter what. And so what are other ways that they can keep themselves safe if they're going to be using alone? And it turns out we have technology like a plain old telephone that can facilitate that. Or actually there's now applications on people's phones that can help alert someone if they have if someone stops breathing or stops moving. So these are ways to connect with someone by phone or video. This approach is called virtual spotting, and it's a way to monitor while or immediately after using. And so here's some examples of that. Never Use Alone is one of the is a nationwide network. They actually have some regionalization, so it's worth going to the website there and checking it out. And then Canary and the Brave apps are two apps. There's other apps as well. Okay, I'm going to check my time. Okay, I'm doing okay. I'm going to talk a little bit about supervised injection facilities and drug consumption spaces and overdose prevention sites. So these are all the names of the same idea. These are legal facilities where people can use pre-obtained drugs under supervision. The objectives are both public health and public safety. The objectives are to reduce overdose, to reduce injection-related infections, to improve access to substance use disorder treatment, to reduce public drug use, and improve neighborhood security. There's research that's been done largely in British Columbia, but also other places that show that each of those outcomes objectives can be realized. There's existing facilities, over 86 facilities throughout Europe, now nationwide in Canada and Sydney, Australia. And for the first time, there's a sanctioned legal overdose prevention site in New York City that opened in 2021. So the evidence for these includes showing, again, in not a randomized controlled trial, but a well-controlled natural experiment of reduced overdose mortality. So here they use population-based overdose mortality rates examined in the 500 meters surrounding this supervised injection facility before and after its opening, and compared with before and after rates in the rest of the city of Vancouver. And in the area around the supervised injection facility, overdose mortality decreased 35%, compared with a 9.3% reduction in the rest of the city. So a disproportionately high increase, which is good, in the area around the supervised injection facility. There are legal and logistical barriers to supervised injection facilities. So, and they're at multiple levels. And this is why we only have New York City with the only sanctioned site, and why it took until 2021. So first of all, there are federal crack house statutes that make it a crime to maintain a facility for the purpose of using substances. Now, several U.S. attorneys And hopefully the federal government is going to change their interpretation of these crack house statutes that makes it more possible. There are state laws, and state laws would have to shield programs from local and state law enforcement. So you need buy-in from the state level, and then local law enforcement, neighborhoods and the business community need to support them. You need to have adequate funding in order to ensure that the program is implemented correctly. And by the way, Rhode Island is another state that has approved supervised injection facilities. They're still waiting through the logistics of finding the right site and the funding in order to open it. And then probably most importantly, you need an empowered group of people who use drugs to ensure that it works. You want to make sure if you build it, people will come and it works for the people who are going to use it. And in Vancouver, that the Vandu Drug Users Union was central to the success of that program. So I'm going to try to show a video here. New York's here. This is from November, the New York Times headline, nation's first supervised drug injection sites open in New York. So there's 2 of them in Manhattan. I am going to switch over to show you this brief video. Let's see if I can get this working. Just bear with me. Here we go. All right.
Since the beginning of last week, inside that facility across the street, the city of New York has allowed people to use illegal drugs like heroin and fentanyl under the supervision of a professional to stop them from dying of an overdose. Sam Rivera is the facility's executive director.
Some people might call it crazy. I use a different C word. To be courageous enough to do this. And we're seeing it. Already 17 lives reversed. Come on.
17 people have overdosed since you opened last week.
Since we opened last week.
And all of them have survived.
All of them have survived.
Hi, Kaylin.
As Kaylin C. took us on a tour, the number of lives saved grew by 1. So an overdose just happened just now.
Yes, it's 100% reversible.
New York City Health Commissioner Dave Choksi, a physician, says opening the facility is based on science. Have you talked to the commissioner of the NYPD about whether or not they'll be arresting people that go into these facilities to use drugs?
Yes, we've had very productive conversations. We have a common mission, which is to save lives. And NYPD and other local law enforcement will not enforce in overdose prevention centers.
When we were inside, there were half a dozen clients using drugs.
No more improperly discarded syringes on the streets, near our schools, in our subway stations. You'll find way less.
On site, safely, securely, without having to worry about overdosing.
The voice behind the divider belonged to a man named Oz, who told us he's a Marine Corps veteran and was using heroin as we spoke.
I've gotten more help here than I've gotten from, from the VA.
Not everyone's convinced. Some worry about sanctioning what is illegal activity. Others over what it could mean for the neighborhood. There's a worry amongst people in the community.
They don't want syringes in the street. They don't want people using drugs in the street. They don't want any paraphernalia in the street. Okay, we agree.
And that's how you're going to stop it.
That's how we stop it.
A harm reduction strategy used around the world for decades, now open in the United States. Jacob Soberoff, NBC News, New York.
Okay, I'm going to get this back up in just a second, I think. Okay, so the latest New York Times story from last week was actually about California. So Governor Gavin Newsom vetoed a bill for drug injection sites in California, and with an interesting rationale, which is hard to square, I think, at least in my opinion. Governor said that he supported the idea of supervised facilities to reduce overdoses and death, but that the state was not yet prepared to put it into practice. So even in liberal places, like California, there is resistance. And even when they support the idea, people aren't necessarily ready to go forward. I want to, again, encourage people, if they have questions, to put them into the Q&A. I'm just now going to run through many harm reduction efforts that I didn't talk about. So these are some additional interventions that really optimize safety. I mean, one is, I think, at the top of my list is decriminalization, which there's countries like Portugal and Uruguay who've had over 20 years of decriminalization and positive impacts. There's drug checking. I mentioned fentanyl test strips, and now there's more sophisticated ways to do drug checking that is evolving. Safe spaces for oversedation. So you can see my colleague Jesse Gata there at the spot at Boston Healthcare for the Homeless, which is a place for people to go when they're oversedated. They're not allowed to use drugs in that space, but if they are oversedated or intoxicated, that's a safe place for them to go. There's bathroom safety. So many bathrooms have been closed down because of the pandemic, but a bathroom is a clean private space where people inevitably are going to use drugs in. And so recognizing that, we need to figure out ways to make bathrooms as safe as possible. Housing and overdose and harm reduction often are overlapping opportunities, concerns. And so housing first, harm reduction housing is another really important thing that we've been thinking about a lot here in Boston, particularly since the pandemic. There's post-overdose public health, public safety outreach, which is an area I do a lot of research in. Managed alcohol programs, much more popular or common in Canada than the United States. Something called bad date sheets, which is a way that sex workers can share information about bad dates in a way that helps optimize their safety. And then I mentioned pre and post exposure prophylaxis. I want to also mention medications for opioid use disorders as harm reduction. And I put up here one of my favorite slides from the National Academy of Sciences, Engineering, and Medicine. There's 7 overview conclusions in the consensus study report called Medications for Opioid Use Disorder Saves Lives. And I'll just highlight number 6. Medication-based treatment is effective across all treatment settings studied to date. Withholding or failing to have available all classes of FDA-approved medication for the treatment of opioid use disorder in any care or criminal justice setting is denying appropriate medical treatment. This is a standard that we are not meeting anywhere, really, maybe few rare places. And I think at its heart, for us to be able to make treatment appealing to people, we need to make it as easy as buying drugs. And so that means having all treatments available in all settings. And so, that is maybe not realistic in the short term, but something we all, I feel like, should be striving for as addiction medicine providers. And another piece that brings the harm reduction, and there's no doubt that medication alone is not enough, but we shouldn't make receiving medication contingent on behavioral interventions, and that would be inconsistent with harm reduction. And so a lack of availability of behavioral interventions is not a sufficient justification to withhold medications to treat opioid use disorder. There's a lot of harm reduction informed MOUD access innovations where we make the treatment work for the patient rather than making the patient work for the treatment. Some of these include opt-out instead of opt-in, ideas like converting detox centers into induction centers, making low barrier access available at hospital and emergency department patients, in jails and prisons, and maybe even at pharmacies, and then having more evidence-based MOUD choices like 24-hour morphine and injectable opioid agonist treatment, which again is evidence-based in randomized controlled trials in multiple other countries with heroin and now with hydromorphone. Okay, so I hope that we achieved some of our learning objectives. I'm at 3 o'clock, so I'm over a little bit. I apologize to the panel. I think we're gonna take just a couple-minute break to switch our screens and monitors and to get started with introductions. And in the meantime, maybe we'll take a look at the Q&A. All right, we're back. That was not the entrance I was hoping to make, so I apologize to everyone. Dawn or Tim, can you just give us the high sign that you hear us okay? Okay, great.
Well,
All right, so let's see here. Okay, so I'm going to take these slides down, but first I want us to do some introductions and introduce this session and our learning objectives. So this is the second hour, and we have our care provider panel on caring for people who use substances. And I'm joined by Emily Lapidus.
Hi.
Would you want to introduce yourself?
Sure, I'm Emily. I'm a social worker on the inpatient addiction consult service at Boston Medical Center.
Great, thank you. Welcome. And then we have Stephen Murray.
Hi, Stephen Murray. I work here in the care unit for Dr. Walley and Dr. Bagley on the Pronto studies. We're studying post-overdose engagement programs. I'm a paramedic by trade and spent 8 years as a lieutenant and first responder here in Massachusetts. And I'm also the founder of one of the programs that Alex mentioned, which is Never Use Alone, Massachusetts. And I also founded New York and Vermont.
Thanks, Stephen. And Teresa.
Hello, everybody. My name is Teresa Raleigh, and I'm a wellness and recovery advocate supervisor in the inpatient service on the addiction consult service at BMC. And before coming to BMC, I was a director of a women and children's exiting out of sex exploitation and sex trafficking program.
Great, thanks, Teresa. So what I'm going to do is I'm going to flash up our learning objectives. And then I think we're going to pause and check out the Q&A, and maybe we'll answer the Q&A together, and then we'll get into our discussion. Does that sound okay? All right. So second hour learning objectives. At the end of this session, you will be able to work in interdisciplinary teams to increase the impact of integrating harm reduction into the care of people who use substances. You will be able to appreciate the value and the limitations of lived experience in providing care for people who use substances. And you will know the harm reduction opportunities and limits of being an addiction medicine physician. Okay, I'm going to take those down. All right, few options. How do I stop sharing? Oh, I got to do it from here. Sorry, everybody. Okay, and I'm going to just go down. We have 9 questions, so let's start at the top, and we'll go down a little bit. Now, we want to keep our answers brief, right? Because we want to get into sort of more of the discussion around those learning objectives. How do they get heroin, fentanyl, et cetera? Are there drug dealers hanging around near the facility? What if they ask for heroin and fentanyl to the facility workers? How do they respond to the request? Okay, so I think this is referring to supervised injection facilities. And that's a great question. I'll just say, first of all, none of us operate or work in a supervised injection facility, but I did present on it. And what is clear about supervised injection facilities is that the drugs are not given to people at the facility. They bring them in from wherever they got drugs outside. So the supervised injection facility or overdose prevention centers do not supply the drugs. There's another intervention, which we called injectable opioid agonist treatment, which is where you go to a clinic and you obtain pre-dosed heroin, called their diacetylmorphine or hydromorphone. And in that case, the actual clinic provides the drug as medicine. But in a supervised injection facility, it doesn't fix the issue of an illicit drug market. It just allows for a safe place to use drugs. So let's move on to the next question. Any studies, likely qualitative, getting information from drug dealers about harm reduction with their products, from Jacqueline Tulsky, one of my original mentors. Jackie, I miss you. Thank you for your question from San Francisco. I'm not aware of any studies, but we have talked about it a lot, and it sounds like you have been thinking about it a lot. Is how do you actually? There's this big gap in knowledge around the drug supply and what patients or people are facing, and an important missing voice there are people who are selling drugs. Many of our patients, many of the people who use drugs are caught up in the distribution of drugs. That is like a part of that. I don't know, Teresa, I see Teresa nodding. I don't know if you want to say anything about that.
Yeah, a lot of the patients that I support, when talking about where they get their drugs from and do they go to the same dealer, it's normally, I've noticed that a lot of them will wait till they get their own monies, buy a certain amount, and then start selling it while they're out there in order for them to have enough for themselves so that they won't wake up. There's a lot of dealers coming in from out of town. There's dealers who come in from out of town, then pay the ones who are out there in drugs to go sell their drugs. So you don't normally see the dealers per se, unless they're parked like 2 or 3 blocks over and they can come back and forth to get what they need to do, and they call it ran up.
Great. So thanks for that explanation. So it for many patients or many people, it follows to be involved in actually the distribution of drugs as a way to kind of continue to use drugs. So of course, not for everyone, but that is something that we do see. And so about as far as qualitative studies, not aware.
There is one. There's one out of British Columbia. I'm going to actually post it in the answer for them. It's Ryan McNeil was one of the authors out of British Columbia. So they did exactly what you were suggesting, a qualitative study of people who use drugs to find out about this. It's pretty interesting. And also having quite a few friends who are doing sort of street level outreach in states where they don't have as developed programs as we have here in Massachusetts. I know that they are also engaging with people who are selling drugs for secondary distribution, as well as using other people who use drugs to extend out how many syringes are being given. So if you can find one person within a social network and you can't access the rest of that social network, you're able to give to that one person, give them 100 syringes, and then they can actually distribute them to their friends. So that's also another method of increasing how much we're getting supplies out into the community.
So using drug distribution networks to actually distribute harm reduction supplies. Has there been any push recently to incorporate methadone treatment into primary care clinics as a way to reduce barriers to MOUD? So that's from Tiffany Strickland. Tiffany, thanks for that question. In many countries, methadone is in primary care. And there was a move called medical maintenance in the early 2000s. There were some waiver exceptions. We actually had a program at Boston Medical Center. There are some other programs across the country, maybe a handful of programs now that do allow with special waivers from the DEA and SAMHSA. They are not growing, and they're mainly reserved for super stable patients. And so I'm glad you brought that up. I think that is an area where there could be some advocacy. There's certainly models in other countries, and there is actually precedent for it in the United States. What are your thoughts on fentanyl test strips? Do they test for fentanyl analogs? So that is a harm reduction question that we should address. So I'll just say that I think I alluded to it in my talk. In Massachusetts, almost all of the opioids that people buy off the street have fentanyl in them. And so we have not been pushing fentanyl test strips regularly for people who are using opioids, really just universal precautions. However, with the surge of fentanyl contaminating stimulants like cocaine and methamphetamine and counterfeit prescription pills, we are recommending fentanyl test strips in those groups much more commonly. And so that's because most of the cocaine and methamphetamine doesn't have fentanyl in it. If you did do a fentanyl test strip and it was positive, that would give somebody information that they wouldn't otherwise have. And so my feeling about fentanyl test strips are that it's a good concept. They're particularly important where fentanyl is present but uncommon, and that we need to keep evolving the technology so we get a really better sense of what's in the drug supply. If anybody wants to add to that.
All I'll add is that there's been a really big expansion in the other drug checking capabilities in the harm reduction programs, especially here in Massachusetts. Most of your syringe programs here across in most regions will either have direct access to more advanced drug checking equipment, or able to send off samples for more advanced drug checking.
Do you see a downside to prescribing buprenorphine at doses higher than 24 milligrams for harm reduction? And so the way I'd respond to that is I'm a prescriber, so I prescribe the amount of buprenorphine that my patient needs in order to achieve the goals that they're looking to achieve. So when I have patients who need more than 24 milligrams in order to reduce their use or stop using, then I prescribe it. That is an ongoing discussion with the patient. It's built on trust. And so I do not prescribe more than 24 milligrams if I believe that the patient is sharing it with other people. And so some people may consider that harm reduction. I'm not comfortable doing that because I'm worried. I don't think it's consistent with my prescribing responsibilities. What I would like to do is encourage that person to bring whoever else they're sharing their buprenorphine with into the clinic so we can treat them as well. Okay, and Lily Lau had several questions which were really about trying to encourage prescribers to participate in buprenorphine prescribing. I'm going to acknowledge them, but set them aside and have them be addressed at the buprenorphine session. Could you repeat your statement about providing naloxone to patients who use stimulants? I'm encouraging physicians to provide it to all of our non-opiate people who use drugs, who use illicit substances. Yes. So this is relatively new for me over the last 3 years, but I have seen, and I have many colleagues, and now we have case report and case series evidence that there is regular contamination of cocaine, particularly cocaine in our area, less so methamphetamine, and then counterfeit prescription pills that have fentanyl in it. And so people are unwittingly being exposed to fentanyl who aren't intending to use an opioid. And so for those people, having naloxone is an important prevention measure. Okay, I'm going to hold on the questions. We'll come back to them. Okay, and now I want to get here with the panel and get your guys' thoughts and involvement here. So, and I just need to look at my notes. Okay, so first learning objective, okay, is working in interdisciplinary teams. And so we have paramedic, who's now a implementation specialist. We have a wellness and recovery advocate supervisor and a social worker. So how does, and I'm going to start with Emily. So Emily, tell us how working in an interdisciplinary team increases the impact of integrating harm reduction into the care for people who use substances.
Yeah, thank you. I think that, from my perspective as a social worker, I kind of build on what the physician is often saying. So building rapport with the patients and then being able to kind of talk to them about their practices and what they're doing to be able to implement so that they reduce their overdose risk or reduce infections. I think a lot of times I'm talking to patients in the hospital about obtaining clean needles and doing tester shots. And that's, and so I kind of just try to build on what the physicians, and then I feel like Teresa and I often kind of we'll team up and talk to a patient, kind of more Teresa, the nitty gritty of their use and their practices.
So with the actual harm reduction practices that you
Yeah.
talk to patients about,
Yeah,
is that something you were taught in social work school?
no.
So where did you learn that? And why do you think it's okay for a social worker to be talking to patients about
That's
that?
a very good question. No, I didn't learn anything about a hospital or substance use. I think that I learned it here at Boston Medical mostly. I mean, I was a medical social worker prior to coming to BMC, but didn't utilize harm reduction strategies or talks with any of the patients really that I had worked with. I think it came to when I started working here, seeing, the patients that I encounter every day who are probably some of the most sick and needy people, in this area, in realizing that my goal as a social worker isn't to try to get them into treatment or to stop using, but it's more to see where they're at. What can I do to help them? They may come in one day and say, I want to get into treatment. I want to get on the methadone clinic, and that's great. The next time I may see them and the plan has changed. And so I think just building that rapport with them and being able to kind of talk to them about, and like I came from more as a person in recovery, just like an I personally am more abstinence based. And I think the last 4 years of being at BMC, I've really gone on the other side of the spectrum. And I find it, I think at first it was a little scary for me, not as just because it's not what I practice in my personal life, but now it's what I do every day and I love it. So
Great. Teresa, how does working in an interdisciplinary team increase the impact of integrating harm reduction into care for people in substance use?
So, piggybacking off of Emily, going in and building a relationship with the patients and having long experience in recovery myself, and a person that wants to learn and learning on the Addiction Counsel Service at BMC and with doctors like you and meeting up with Tim and everyone else who's a part of this breakthrough of harm reduction for the population that still struggles. I want to learn about it. Like when I was out there, our substances wasn't as contaminated as it is today. So when I came here and I noticed that patients didn't even know what fentanyl was, or that fentanyl wasn't even in their system. And you would ask them, well, what did you use today? And they'll go, heroin. And we'll go, oh, there's more than just heroin in there. And it would surprise them. It made me realize that we needed to be educated more on what was going on out there. So I wanted to learn. So I learned here a lot about harm reduction, because harm reduction hasn't been out there as long as I've been out there. So when they came in and they first say, and I must be very transparent because that's who the woman I am today. When they start talking harm reduction, I was like, what the hell are you talking about harm reduction? Like we need to save these people's lives. But then I learned I had to take the superwoman cape off and learn a different way and have a change my way of thinking on how we can help save these people who are still struggling and let them be able to show up for life. And that's through harm reduction, period. And the more that we educate about harm reduction in different ways that we can save the population's lives, because one day they might just say, you know what, I woke up this day because of harm reduction. Maybe I might want to go into treatment today. But if we don't get educated about what's going on, because what's going on out there is not going to change, it's going to get worse. So why not learn about what we can do with what we have today? And that's what I wanted to do. And I love this.
Stephen, interdisciplinary team. So you have lots of experience as a paramedic, but not in the hospital, before the hospital. And so what's your thoughts on how integrating harm reduction impacts those interdisciplinary care that we're trying to offer people who use substances.
So I always looked at it as like almost we were the intersection of two different teams in EMS. So you have your sort of public safety team, which is police, fire, and EMS, and then you have your hospital team, which is all the folks that we're talking about here. So since they were talking about the hospital, I'll talk a little bit more about the pre-hospital public safety side, which is that when we have interventions that we're working on as a state, so public health goals, everything you talked about, so increasing syringe access, but then we have law enforcement officers who are confiscating those syringes in the field after an overdose. We're having a clash of sort of the plan to like help to reduce those deaths. So bringing everybody to the table to talk about like what are our goals here, what are we trying to do? We want to have more firefighters carrying Narcan, but we don't want them to give 4 doses in 3 minutes because it's going to make withdrawal worse, which is going to make the patient less comfortable. It's going to make the ride to the hospital more difficult. It's going to make their stay in the hospital less successful. So I think that all of this stuff, it all moves downstream. And so we have to continue to find places to make a difference along that sort of continuum of care, because it starts before EMS. It starts with the first officer that shows up for an overdose and the firefighter that shows up behind him, and then the EMS provider that shows up after that and moves its way through the chain.
I want to go on a little sidebar. We'll try to be quick, but it's a really important point because this audience is addiction medicine fellows, right? So you just talked about overdose response, and as a paramedic who's responded to a lot of overdoses, what is your goal during an overdose response, and when do you use naloxone and when do you use other measures?
It's a good question. So yes, I've responded to a lot of overdoses, more than 100 when I was working in the field. And I think that my goal changed over time as I became more confident in my sort of the other skills that come with responding to an overdose. And so like supporting someone's breathing with a bag valve mask, you could do that all day if you're good at it without actually ever giving them naloxone. And so I saw the sort of total, as we were hearing that we needed more and more naloxone for overdoses, I actually found over time I was giving less and less and having better outcomes where people would, I would only give like 0.5 milligram, bag them for 10 minutes, and they would restore their breathing. And because fentanyl is such, it's so strong, but it's also shorter acting, that sort of like really bad time that they were not breathing was not quite as long as with sort of longer acting opioids. So did I answer your question? I guess.
Yeah, you did, you nailed it. I just want to emphasize this point that you made, which is that in the experienced healthcare responder, the goal is really to support oxygenation. Right. It's not the restoration of a high level of consciousness immediately, because if you focus on the reestablishment of a higher level of consciousness, of waking people up, we're going to overshoot and we're going to cause precipitated withdrawal, which is traumatic not just for the overdose survivor, but it's traumatic for the care team. Like I was an EMT at one point, and I had the experience of being in the back of an ambulance with somebody who was in acute precipitated withdrawal after receiving naloxone. And it's not a fun experience to be there. And so, it's better than them being overdosing and dying for sure. But optimally, we want somebody comfortable in the back of the ambulance, and we want to keep them comfortable while they're in the hospital. We want to treat their withdrawal while they're in the hospital, even if they're not interested in treatment, right? Because we want them to stay in the hospital and complete their care, complete their medical care. And so anyway, that's, I think, an important, like, higher level medical, like, issue around overdose response. And you've taught me that, and it's something I also experienced.
And one more thing on that same idea is what I realized was that the second dose of Narcan that people were often giving, like in the 3-minute mark, the person would shoot awake right when that second dose hit. And I realized it wasn't the Narcan that was doing it. It was that someone was getting something sprayed up their nose, and that was enough to stimulate them to wake up, which lets us know that actually they'd already had enough Narcan prior to the second dose. And so once I stopped this sort of like practice of stacking doses and sort of easing people back in and actually paying attention to what was going on with their breathing, rather than sort of what you hear a lot in EMS, unfortunately, is that they want the person to walk to the ambulance. They don't want to have to carry them. And so part of that is that they try to do things as quickly as possible. So you're trying to wake the person up so they could walk to the ambulance and then go to the hospital. And that really is not best practice. What we want to do is we want them to wake up when it's time for them to wake up. You want to restore their breathing, support their breathing, and let them come back to being responsive on their own.
Great. Thanks for that little sidebar. Okay, I think that you each mentioned your lived experience. And so second learning objective here of this hour is to appreciate the value and limitations of lived experience in providing care for people who use substances. So starting with you again, Emily, do you want to speak to the value and limitations of lived experience as a care provider in caring for people who use substances?
Before you start, we got a reminder just to speak a little bit louder.
Oh.
That's a great.
Great.
Thank you. Yeah, thank you. So as I mentioned before, it's, you know, I've been sober now for 14 years, and I never, when I was engaging in treatment, never once heard about harm reduction. It was abstinence based. And you know, for me, I think that was probably the best way for me to get sober. But I also understand that my life circumstances are very different than someone else who may be living on the street or doesn't have, you know, I came from a family that had some resources, and so it was a difference. I think that, you know, like I said, as a social worker, you know, I don't disclose to my patients that I'm in recovery, but the way that I kind of connect with them, and I think sometimes they'll kind of look at me like, you seem to know what you're talking about, you know, without me saying it, is because I'm able to understand, and I can identify with them on what it feels like to be struggling, and, you know, kind of the ambivalence of like, do I want to stop? Do I want to get treatment? How's my life going? And so that's, you know, how I've kind of utilized like my lived experience into my social work profession. I think that, and, you know, and maybe that'll change. I mean, it was only probably the last couple of years that I even told people at work that I was in recovery. So, you know, it's for me, it's been, you know, I guess you know, it takes a long time. But, you know, maybe one day, you know, I'll disclose, but I think for me, it's more of, you know, as a social worker, what is the reason behind the disclosure? And I think that's one thing that I learned, you know, in social work school was, if you're disclosing something about yourself, what is the purpose behind it? And I don't want the purpose behind it to just be like, well, I'm in recovery too, you know, and so, because like I said, my lived experience is different. And I'll just end with the fact that, again, I personally, you know, come from I'm going to abstain from all substances. But I think in the 4 years that I've been at BMC, it's completely opened my mind, because like I said, prior to that, even as a social worker, when working with patients with substance use disorders, it was more about like, how can we get you into treatment? What's your motivation for change? But it wasn't necessarily like, where can you get clean needles, and how can we prevent you from coming into the hospital so that you don't get the infections? And what Teresa and I and a lot of people on the addiction consult service say all the time is like, our patients aren't coming in necessarily to stop using substances. They're coming into the hospital because they have an infection, or they're sick, or they just overdose. And we're going into their space and trying to take that as an opportunity to give them some resources. But I think that's what we have to remember is, you know, they didn't necessarily come through the ED saying, you know, today I want to stop using.
So, Emily, you are a master at getting people into treatment. You're really like our go-to person. And so some people may be listening thinking like, well, with that harm reduction attitude, like nobody's ever going to want to go to treatment because, you know, we're not pushing them to do it. But you're placing people in treatment every single day.
Yeah.
So can you talk a little bit about like what you observe as far as that evolution? Like, do you have some like special powers where you're able to like get people to go into treatment? Or is it about like waiting till people are ready or building a relationship? Like
I think there's many reasons. I think that, you know, I started talking to patients recently because I connect a lot of patients to methadone treatment. And, you know, as I've learned from the physicians, you know, they're a lot of times not going to be going into the methadone clinic on a therapeutic dose. And so I try to tell the patients, well, what if you try to get into the clinic, and even if you have to use, maybe it's going to be, you're going to be using less. And the methadone will hopefully help prevent you from overdose. And so I'm trying to utilize that technique, especially for the ones that are saying, you know, they want to be on methadone while in the hospital to treat their withdrawal. And so taking that opportunity, because a lot of times once they're started on a medication for their opioid use disorder, they're going to feel better. And so that's when we kind of can come in and be like, wow, like you feel a lot better. What can we do to help you get to a place where even if you don't want to stop using completely, maybe it's a little bit less or less risky.
Great. Teresa, what are the strengths and the limitations of lived experience that you bring to your work?
I think being able to identify with some of the trauma that goes on with our patients. Like Emily said, certain things that we'll say will have them feel like we know a little something about what they might be going through. I am a person that will disclose some of me because I don't want to traumatize them anymore, but I am a person that will disclose some of me just to build that relationship depending on where they're at. Always remembering that they're not coming there for treatment, harm reduction, relapse prevention, or anything else, but because they're sick. And the only reason why they're not using at that minute is because their body is saying, I can't take no more, or they've overdosed. So I always bring up Dr. Brazelton, may he rest in peace. He talked about a touch point. That when you feel there's a touch point that you can get in, whatever it is, then go in. So if I do a lot of emotional listening, because that's when you get to know where they're at. I'll go in and introduce myself because a lot of times they're sick. Just to let them see my face and let them know that I'm not going to push them, but I'm concerned about them. So I'll go in and I'll introduce myself and ask them if there's anything that I can do to help them. And it could be just get me a cup of ice. And I heard them say, get a cup of ice. If that's important to them right there, I'm going to go get them a cup of ice. And I'm going to say, here you go. And is it okay for me to come back the next day? And I'll come back the next day. And then that day I'll pull a chair in with me and I'll sit down and just ask them how their day's going. Trying to build that, the relationship, because I know when I was out there, we didn't have a lot of the resources that we have today. Like maybe 40% of what they got today, we might have back in the day. I just celebrated 24 years. And like Emily's from absence from everything. So when I go in and we bring up harm reduction, it's more or less on, again, I always say this, it gives them a chance to live. If you want to use, and we know they want to use, and we all know that until a person's ready, they're not going to be ready. I knew my son couldn't get me ready, my mother, my father, my friends, nothing, something outside of me, for me, had to get me ready. So I have to remember that if that person ever gets ready, it's on their terms. So until then, what can we do for them today? Harm reduction. So we talk about the safety, OBOC, clean needles, not using alone. a lot of times they feel more comfortable when you're talking harm reduction instead of pushing things down their throat. See, but I'm talking harm reduction. There's a method to the madness. You know what I mean? We know that.
Yep.
So if we can just get them to go ahead and say, you know what, I'm comfortable with talking about this. Yeah, give me a card, give me a number for where I can go get this or where I can go get that. And me and Emily, sometimes we go in as a team because we have some that we are very concerned about that wants methadone, but don't know how about getting methadone or feel stigmatized about the methadone, or people telling them that you're still relapsing or you're still using. So we come in as a team, thank you. And she'll talk about the methadone process and everything. And I'll talk about the stigma that goes along with it. And I'll bring up the big book, the basic text. If you go to a meeting, that book is in every single meeting across the world. And on one page, and I'll stop with this, on one page, it says, any prescription prescribed by a doctor, it's not a relapse. And if you flip that page, it says some of us need outside help. It's not just therapy, it's not just counseling, it's medications. So the person who knew that book knew that there was a process that's going to happen, like fentanyl. So it's okay to use it, and I commend them. That's a great idea because methadone is a great medicine along with Suboxone or Vivitrol or anything else that we have to offer, because it's giving you the opportunity to do what you want to do in a safe way. So that's how I bring mine to the table.
Great, thanks. Stephen.
So I'm really cautious with lived experience in a sense that like there's a confirmation bias that's associated with it, which basically is that like something worked for me, so it should work for you. And like I always ground myself in thinking that like I went through the same treatment as everybody else in the program that I was in did, and most of them didn't live past the first year. I also have more than a decade in recovery, and part of making it to this point and the flags that you brought up, like I know a lot of those people, a lot of those flags, you know, those flags are like people that I care about and, you know, that I miss, and, you know, so, and then lived experience is not living experience. And in a decade, a lot has changed, as you showed, like in your presentation, like the situation on the ground is different. Like what I went through is like not what people who are using today are going through. What people who are using today are going through is different than a year ago. And if we look at like the introduction of xylazine, for example, into our supply here locally, that's a whole nother set of problems. And so my lived experience has a lot of limitations there. What it has given me is that I understand medicalized trauma. I understand how it feels to lose people. I understand how it feels to have nobody trust you, and how hard it is to like regain that trust of the people that you care about. And so like I know my limitations. I know where, and I started disclosing as an EMT early on to patients long before I felt comfortable disclosing to my coworkers. And that speaks volumes about where we are, that I felt more comfortable with people in the back of the ambulance than with my partner in the front or with the doctors and nurses that I was working with. And so that took me 6 years of being in EMS to feel comfortable to disclose to the people I was working with. So we have a long way to go.
So Teresa mentioned trauma, and then you just said medicalized trauma. So I want to hear more. I think I know what you mean, but I want to hear what you mean by that.
Yeah. So as I said in the last question, and I like the touch points concept because it's good for this describing this answer, but there are a lot of touch points in the sort of continuum of care where you have a lot of opportunities for people to treat you badly, to treat you poorly. And for many people, it starts at the very beginning with law enforcement, and it goes all the way through even to addiction medicine treatment providers. And so I always thought of myself as like that one little dot where it's like they'll get some love and like just like radical acceptance of who they are and like what they're going through, and like without any conditions to that. But you know, even within the sort of like setting treatment goals and those sorts of things, a lot of times you're just trying to make the other person happy by accepting these sort of ideas and these goals. And so I like what you were saying, like you kind of like have the person come out with what they want without like kind of feeding it to them. Because if early on, if someone had said to me, oh, it's a really good idea to do this, I would have just said, sure, I'll do that just to make them happy and to get them off my back. And so, yeah, it can be really subtle things like that. Like to me, that's like the sort of like small traumas all the way up to, you know, not having your pain treated in the emergency department because people know that you use drugs. I've seen people who had traumatic injuries that were horrifying, who were being denied pain medication because they were on Suboxone or on methadone. And so like that's sort of the more egregious things that I've seen. But yeah, just the way that they're talked down to, that people are talked down to, it's pretty disturbing.
So for many people who use substances, the experience of seeking help in a healthcare setting actually results in more trauma. So I think Emily and Teresa, like that's internalized into your work. Like you're tuned into that. That's the expectation when you go into the room, that you're like, you know, you're going to support people with that particular issue, that this may not be the place that they want to be, not just because they don't want to face what's happened to them, but because they've had experiences in similar settings that were not great. So that gets to kind of the third learning objective, which is what are the opportunities and benefits and limits of being an addiction medicine physician? So we were just talking about like, you know, how a medical setting can be traumatizing. And you even alluded to the fact, or you didn't allude, you were specific saying that addiction treatment sometimes can exacerbate or trigger the trauma that, or the stigma that people have had. And so this is an audience of physicians. What are the things that you guys have seen that physicians should not do? And what are things that maybe they should do? Or you know, or when are the times that they should defer to their colleagues?
I think, you know, I'll just say from my experience too, it's like being in settings where, you know, previously being in emergency rooms and outpatient treatment and inpatient treatment and all of these things. I think as a person who's lived it and then now working alongside people, the one thing I hated the most was like, you come from such a good family. Like, why are you doing this to yourself? And so that was always, I never wanted to feel, I always felt like I was being picked out, but more in the sense of like, you're upper middle class, white, young adult, like you have your whole life ahead of you. And I just wanted to say like, shut up. Like,
And how does that make everyone else?
Yeah.
Everyone else in the room feel that they're picking you out on this top, like that they aren't worthy of all those other things too.
Exactly. I went to treatment programs where I was the only person who was housed. You know, I didn't go to these fancy treatment programs because that's, my parents said, you're going where insurance covers. And I went and I didn't want, I knew internally how grateful I was to have the support that I had, but I also never wanted to feel like I was better than someone else who was in a bed next to me. And I think that I got it a lot, and it pissed me off because I'm no better than the person. I was just born into one family and someone next to me is born into another. So I think the biggest thing is, you know, as a physician kind of coming from this, just be wary of coming from this kind of paternalistic kind of view of trying to really say like, I know what's best for you. Because you don't always.
Oh, what should doctors not do? What are things like? they can do?
I think words matter and the way you talk to patients matter. Patients are already sick. They're already feeling a lot of baggage and thoughts in their heads on what's happened to them in their life or before they came into that hospital. And because a lot of times when they come in and they're starting to feel better, that's when they go up into their head and they start thinking about the open cases. DCF taking my kids, or I just had a baby and they're looking at me like I'm crazy because I feel like I want to use, and they don't want to speak that because of the words that might come out of clinicians' mouth, staff's mouth, whatever. I've heard one, this is just my personal experience real quick. I say this all the time. I've given out adult coloring pages to people who like to, we're human beings. And I was coming out the room and I just happened to be checking my phone and I seen a doctor and a nurse walk by the room and did a double take and was like, what are they doing? I'm like, they're coloring, they're human beings. Like, well, they didn't hear me. And I said, well, can I talk to you for a second? Because, you know, we don't like audience and I don't want them to think that you're a doctor and I'm not. And I think I know more than you because I don't want to, but I just want to educate you that she's a human being or he's a human being. And we didn't want to grow up to be addicts. So when I say we, they look at me like, okay, because you see this on and you might see me dressed like this, that I don't have a story. Like, you have to be careful on what you say around who you say it to, because you don't know who's been in this process before. And like Emily, like I really didn't come out at first, but then when I seen how important it was to educate, because if you don't know, you don't know. So I try to educate as many as I can with what I know, and what I don't know, I'll try to find out, because I don't want to give out the wrong misinformation, because we've all been lied to out there. And it was hard for us to trust when we was out there. So if I don't know something, I'll tell that person, give me a little bit, let me go find out to make sure that that information is correct. And I educate. And a lot of the staff now knows me from going from floor to floor to floor, and sometimes they'll stop me and ask me different questions, and I'd be happy to tell them, because words matter. We're doing a words matter pledge in a couple of weeks, and I'm hoping to see everybody come out and talk about that, because overdose awareness is not just for a month, it's every day.
Yep.
So whatever we got left over, you'll see me going in the hallways. It could be in December. And I say, here's a pen, or here's a t-shirt, or here's a this, because to me, overdose awareness should be every single day and not just once a month. So it's about educating.
Yeah, so I'm glad you mentioned today is Overdose Awareness Day, but absolutely, it's those 20,000 deaths in Massachusetts, they didn't occur just on today. They occurred every day, every single day. Somebody's dying of overdose. In Massachusetts, September is Recovery Month. So it is fitting here that I think that we start off this month, where we, highlight more on recovery. We started off with overdose awareness.
Mm-hmm. Wonderful thing, Alex.
Yes, it is. And the Words Matter pledge is something that we've been doing at BMC for a while now, which is one way to address stigma among the staff and people here. I just have to mention adult coloring books. So,
It's the best.
Yeah.
okay, so over the weekend, I was out and talking with friends, and one of the people worked at a high-tech startup, and they have activities where they cope and bond with being remote, and they do group adult coloring. And I told them about our experience on the consult service and how, it's not enough, but it is a tool that we use regularly. And then, of course, somebody made the comment, like, what kind of adult are you talking about? So anyway, that's, they're not that kind of adult. They're really, somebody made the argument that it's a type of mindfulness. I don't know if there's research for that, but anyway, okay. So Stephen, you've been in lots of situations with physicians, and so, what can you tell this group about do's and don'ts
So I have two thoughts. One is around, so as an addiction medicine physician, there sometimes is an assumption that every patient that comes to you has substance use disorder. And so taking a step back and thinking that, well, first of all, we have a little bit of a tendency in this country to think that because drugs are illegal, all drug use is somehow disordered. And so I would just argue that that thinking can be dangerous. And to give an example, my cousin, who's a year younger than me, he was put into treatment for being caught with weed when he was a teenager. And in treatment, he learned a lot about other drugs, and which started to push him down a different path. And so he was actually exposed to other drugs as a result of treatment, whereas he had just kind of been like a teenager who was messing around. And he's still in active use today. And then the second thing is that when you're burnt out, you need to take a break.
Yeah.
I left EMS almost exactly a year ago to come here. And it was because I was burnt out. And I know it in myself that when I'm not bringing my best to patients, that it's time to take, and I used to take mental health breaks as well when I was working, because you're no good to somebody if you're feeling burnt out. So take a vacation, get yourself off the rotation for a bit, recharge, and then go back to it, because it's when you're burnt out that you make comments that you probably wouldn't have made when you're at your best.
And that shows how much you love your position to know that when you get burnt out, let me go away for a little bit so I can come back and be refreshed with the patient. Not let me just go and don't come back. You know what I mean? That self-care, we talk about it all the time. Self-care so that we can come back and be the best we can when we come back. Because we're not going anywhere. We love what we do. And plus they need us.
We're getting
Thank you for those.
you to take a look at our questions.
Yeah, I think it's a good time. That's a great note to end on. As somebody who's taking a sabbatical and has a lot to learn around self-care, I want to just put an exclamation point on that. I'm just going to jump into these. This one, actually, I haven't read the whole one, but I think it's one we should tackle before the end of the hour. So hello, thanks for the interesting topic and probably the most needed one at this time. I was reluctant to ask this question due to the importance of harm reduction. My question for you is, where is the equilibrium level point between facilitating the safe usage of substances, the substance use prevention, and not to be like advertising for the usage and ramping up the usage by our facilitative activities? I know that this is more related to policymaking level and not to the provider level that I and the other physicians like me on. Also, this might be one of the concerns that liberal states like California has. I'm just speculating. So I'm really grateful for this question. I think it's important for us to kind of explore as a group. So who wants to take that?
I mean, I can kick off on it. So 100,000 people died last year from overdose. And I think that at this point, people are using drugs. We've tried to reduce demand. We've tried to reduce supply. Neither has worked. All we've done, we've criminalized. All we've done through reducing supply is made drugs more potent through the sort of iron law of prohibition. And so I would argue that making it safer to do drugs would have little impact other than to reduce the amount of people that die from using them. As you could see in the numbers, when we had really, really easy access to prescription opioids, our deaths were about a fifth of what they are today. And so cracking down and making them illegal may not have worked. So I would say that I would not think that would increase the amount of people who are using.
Great. I will make a comment, which is that I think that there's a difference between decriminalizing and commercializing. So I particularly like the commercialization of nicotine and tobacco generated harms and killed people. And so that, you know, and the same is true for alcohol. You know, selling alcohol to kids increases the risk that they're going to be addicted. Prohibiting or punishing people who, like kids who are drinking, I think is like problematic. And so not necessarily the answer. So criminalizing, I think, is not the answer, but commercializing is the extreme that can really cause harm because of the developmental brain and the difficulty of, if you have commercial products that are, particularly if they're being sold in a capitalist system, the people who are going to win are the people who sell those addictive substances to kids. So I personally think that I'm fully for decriminalization because of the harms of criminalization. The criminalization is the extreme version of stigma. And so what you're really doing is not just telling people that drugs are bad, but that people who use drugs are bad, and they're not bad people. And so that's the problem. And so the line that we need to walk, I think, is decriminalizing, but not commercializing. And that can be tough because of the, you know, the way our society really elevates, you know, selling products essentially. So I don't think that fully answers your question, but I think your question is a really important one that we have to wrestle with in harm reduction. At the end of the day, I think there's a lot more stacked against people from using negative consequences without us piling on. By piling on negative consequences, I don't think we're making it very far. We need to positively reinforce treatment. Like I said in the talk, we need to make treatment work for people rather than make people work for the treatment.
I like this question here.
Go ahead and read it.
So there's a question. We were in a discussion today with New York State Substance Use Oversight Body about expanding our fellowship program to allow training of multidisciplinary team members to have social workers, mid-level providers, pharmacists, et cetera, be trained within the addiction medicine fellowship setting. What are your thoughts about how to go about building a program like this? I think we've taken some steps here. I mean, I'm like an honorary fellow, and I'm a paramedic. I join the weekly meetings quite often to hear about things, and I know that a lot of the other folks is pretty open here at BMC as to whether or not you can participate in a lot of the activities that the fellows are up to. So I think it's a great idea, personally.
The more the merrier.
I think it's awesome that Teresa and I and our MPs are able to attend the weekly didactics and the case conferences. You know, and I think that we've done a really great job here at kind of integrating ourselves and being equals amongst all the providers.
Tilda Beth, thank you for that question. One place that is doing this, not just in spirit, but in actuality, is University of British Columbia, St. Paul's Hospital. They have a nursing fellowship and a social worker fellowship, and they train alongside. I'm going to do a selfless plug for Immersa, which is a multidisciplinary education organization that welcomes all addiction providers and tries to elevate the education and research conducted by those providers. And so I think that ACAAM has a lot to gain from being open to other disciplines. I do think that addiction medicine is still a relatively young and potentially threatened specialty. So we need to make sure that it's prioritized among physician training, but that is not in competition with prioritizing it in the training of other disciplines. In fact, it's complementary. But it's a great question. I'm conscious, I want to acknowledge that we're at 4:01. I want to get either Dawn or Tim's view on whether we should keep going or whether we should wrap up.
This has been great. I think we can probably see if there's any questions that you feel like need to be addressed. If not, let me know and I can send us on our way.
Yeah, if there's anyone who we didn't answer your question, we would be happy to answer it offline. And we're going to do a quick scan here to see if there's anything crucial we didn't miss. I'll just highlight that anonymous attendee put in fentanyl test strip information with a nice on the issue around analogs. So thank you for that reference. We'll direct people there. How fearing from going to withdrawal status might be a barrier for an opioid user to easily accept using naloxone. I'm just going to make a quick comment about that, which is that is definitely a real phenomenon. And that is the reason why this concept of a Narcan party, which you might have heard of, it's an urban myth. It's not something that it actually happens in the real world. Somebody who has opioid use disorder with opioid physical dependence, the last thing they want is naloxone. The way I work with their fear of naloxone is I say, hey, I'm giving this to you to have you be mindful about your own overdose plan, but most likely you're going to be using it to save someone else. And that's really what typically happens. So I have a lot of my patients who, yes, I talk to them about their overdose plan, but the reason they take the naloxone is because they want it to be able to rescue their friends. So that's one way to work around that fear. Someone asked for the book for us to read. Which book was it? Oh, I think it's the big book.
NA big book.
Or 12-step.
Yeah, you can just Google 12-step NA big book.
Or AA.
Or AA big book. Okay, great. And we got some comments from Dora. Thank you for those. Okay, I think, Tim, we handled it. And if there's anybody who wants, to get to us, you should be able to reach us through the website here, or we can put in our email addresses.
Well, Alex, Emily, Stephen, Teresa, really, thank you so much on behalf of the American College of Academic Addiction Medicine. Really appreciate all of the time and effort and candor that you put into today's session. Very much appreciated. For any of our new attendees, if you do want more information or education from our great organization, please feel free to check out our website, ACAAM.org. That's ACAAM.org. Again, we take no pharma or industry money. We're very proud of that and grateful to our members. So thanks again for everybody who joined us. Enjoy the rest of your week and be safe.
Take care, everybody.
Take care.